Hello, everyone. Welcome to BrainMap. So this seminar is co-sponsored by the P41 Center for Mesoscale Mapping housed at Martinos. So I will just hand over to Dr. Steve Stuffelbein to give us the introduction to our speaker today. So Steve.
All right, thanks, Abbas. So I'll just give a brief introduction to Christos. He's a good friend, colleague, and collaborator for many years. I think I first met Christos 15 years ago when he gave a job talk here. And I discovered that he's the first person to do an MEG on a watermelon. It was fantastic. It was actually great work making a phantom out of a watermelon. But over the years, we've collaborated quite closely on epilepsy research. A few years ago, we got a joint R21 when he was at Children's Hospital, which was flipped into an R01. But he soon left us and went to Texas to Cook's Healthcare System Hospital, where he runs the MEG Center, which is both a research and clinical device. And he also has an appointment at University of Texas, where he has another large group. So it's always a pleasure talking with Christos. I went and I visited him a few months ago. Yeah. He gave he put on a conference for the Texas Consortium of MEG. And somehow I got invited too. It was sponsored by Megan, who makes our MEG. And I was just so impressed with his facility. You know, the hospital itself looks like Disneyland. It has all this topiary stuff and beautiful lights. And then his center downstairs has this wonderful tiled floor with magical colors on it. But in any case, I'm looking forward to his talk, and I will let him give his background because it's quite complicated because he's so well accomplished. But in any case, Christos, it's my pleasure to listen to your talk. Thank you.
Okay. Thank you, Steve, so much. So good morning, everybody. First of all, I would like I'm Christos Papadelis. I'm the Director of Neuroscience Research at Cook Children's Healthcare System. And today I will talk about the presurgical evaluation in children with drug-resistant epilepsy. And as Steve said, I will give a brief history of myself. I was born and raised in Greece. I graduated from the Aristotle University of Thessaloniki. It's the largest university in the country. My PhD was on the development of an EEG-based biomarker for the detection of the level of the sleepiness from drivers on board. I had my first postdoctoral research training in Brain Science Institute in Riken in Tokyo, in Japan. I worked with Professor Andy Ioannidis. I was working most source modeling with Meg. Then after 3 years, I moved to a very beautiful place in the middle of the Italian Alps in the University of Trento. I work with cognitive neuroscientists there, emotional processing, and Christoph Braun. Eventually, I was offered my first faculty appointment here at Harvard Medical School as instructor in neurology back in 2011 and manager of the BabyMake facility in Boston Children's Hospital. I had set up my whole team there, Children's Brain Dynamics. I was promoted to assistant professor and director of the clinic. And eventually, after 8 years in Boston, I decided to move to more warm climate down in Texas to set up the research center at Cook Children's Healthcare System. So that's me, and these are my financial disclosures. And today we'll talk about epilepsy. Epilepsy, a common neurological disorder, is characterized by recurrent seizures. It occurs in almost all ages, but is more common in children. So it has been estimated that approximately 500,000 of children in the United States, they suffer from epilepsy. So it's a very common disorder. And the first line of treatment for patients with epilepsy, it's through use of anti-seizure drugs. We have now more than 40, We have more than 40 drugs to treat epilepsy, but unfortunately, despite of all these efforts, like 30% of the patients with epilepsy, they suffer from what's called drug-resistant epilepsy, so they're unable to control their seizure with drugs. And patients with epilepsy, they don't suffer only from recurrent seizures, they have cognitive problems, they have other comorbidities, depression, anxiety, they have increased mortality, greater risk for sudden death, a condition that's called SUDEP. For this patient, the best available treatment is epilepsy surgery. The goal of the surgery is the complete resection or disconnection of the area that is called epileptogenic zone, is the area that is indispensable for the generation of the seizures. And epilepsy surgery is quite effective treatment. It has been estimated that 60% of patients, they remain seizure-free at least 5 years after surgery. While its efficacy and safety has been significantly improved the last years, there's no need for this big craniotomies in most of the cases. We open a hole on the patient's scalp, we place a probe inside there, and we deactivate the epileptogenic zone with laser ablation with heat. Before the epilepsy surgery, the patients, they come for the presurgical evaluation in order to identify which area should be resected. This presurgical evaluation consists of two phases, or the phase one, where we have like a bunch of non-invasive tests, like the MEG and the high density and some others, like we'll see that later. The idea is like we try to pinpoint roughly where the area of the epileptogenic zone is located. And then when we formulate a nice hypothesis, then patients go to what's called phase two, where we place intracranial electrodes inside of the brain in order to identify with higher precision which area that should be resected. The problem with the epileptogenic zone is kind of theoretical concept, so there's no kind of tool or method to assess this area in a direct way. Instead, we assess the epileptogenic zone indirectly by mapping several cortical areas on top of each other. And among all these cortical areas, the most easy to assess is what's called the irritative zone, is the brain area where the interictal spikes, they occur. And interictal spikes, it's a very sensitive biomarker of epilepsy, can be seen in all patients or most patients with epilepsy. And it's very easy to see because they occur very often. This is the state-of-the-art system setup we have at Cook Children's. It took us some effort to make this kind of establishment, allows like the simultaneous recording of MEG and with more than 550 sensors covering the entire child's head. It's a very child-friendly procedure because this kind of EEG system does not require any conductive gel. We have sponges which are attached next to each electrode. We just soak the net inside of a bag with a saline solution. These sponges, they become conductive. We place the head on the child's head and we start performing the recordings. This is what we're trying to see in the EEG and the MEG signal. This is simultaneously EEG and MEG recordings. We identify this kind of interictal spikes. And the goal we have is like to recognize the underlying sources inside of the brain, either on the cortex or in the volume, which are responsible for the generation of this kind of activity. But to do that, we need to solve two complex mathematical problems, the inverse problem and the forward problem. By using the inverse problem, we actually map or project the activity that is recorded non-invasively with the MEG or the high-density EEG inside of the brain, and we got this kind of source activation maps. And for dealing with the inverse problem, there's two kinds of groups of methods. They are the equivalent current dipole. It's mostly used in clinical practice, and the distributed source methods. I will not go into details, but just briefly, the equivalent current dipole, it makes an assumption that all the observed activity at one specific time point can be modeled with one dipole that has a specific location, orientation, and moment. While with distributed sources, we make an assumption there's a larger area that is extended there that is active, and we make some kind of assumptions in order to find the actual. In clinical practice, as I said, like the dipole fitting is the most suitable method. We identify all the spikes and we model them with one dipole. And then that's the desirable case, a group of dipoles in a focal area of the brain, which is nicely formulated cluster. There are several studies now showing that if you resect this cluster, it becomes seizure-free. And one of the first persons who test the ability of the EEG and the MEG to localize the brain activity is David Cohen here in Boston. He actually found that the MEG has an error around 8 millimeters, while the localization error for the EEG was around like 10 millimeters. Another way of assessing the localization abilities of the MEG and the EEG is by using constructions that they resemble the electromagnetic properties of the human head. One of the first work was done by Leahy and his group. He used a human scalp. He placed dipolar sources inside of the scalp. He activated these sources with sine waves, and then he tried to localize this kind of activity with MEG and high-density EEG. And the figures is from my work. As Steve he mentioned, I started working with a watermelon. I placed several dipoles inside. That's work from my postdoc in Japan. I used a phantom construction that was made out of plastic. I placed several dipoles there. I published this work back in 2007. And nowadays we have an ongoing project with Steve Staffelbein and the group here in MGH that we design and we develop a 3D printed phantom that resembles the different properties of electromagnetic properties of the different tissues in the human head. So in this side of this, we place several dipoles, dipolar sources. We activate these sources with recordings, invasive recordings from an actual patient with epilepsy. And then these are very preliminary results from this project. We managed to generate artificial enterical spikes that can be seen nicely both in the MEG and in the high-density EEG. They resemble like quite closely the enterical spikes in actual patients' recordings. A first attempt to localize this kind of activity was that the MEG has a localization error of approximately 8 millimeters, while the high-density EEG around 11 millimeters, like similar findings and values with what David Cohen produced like several years ago. Another way of assessing the localization accuracy of the MEG and the EEG is by using actual data from patients with epilepsy. This is a project that was run here in Boston. Assessment of 3 different neuroimaging techniques: the low-density EEG with 20 channels and no co-registration, the high-density EEG with 72 channels, and the MEG with 306 sensors. We look at spikes, and we see here a nicely formulated cluster, more loose with the EEG, low-density EEG, with more focal with the high-density EEG, and even more focal with the MEG. And we compare this kind of activities, non-invasive activity, with the invasive one. This is the measures we used for assessing the localization accuracy, whether the dipoles, they were within the coverage, the distance between the non-invasively localized dipoles from the invasive ones, and the distance from the resection. We found for the MEG, 92% of the dipoles, they were for good outcome patients, they were within the coverage, 80% for the high density EEG and 70% for the low density EEG. And that was a localization error around 14, 15 millimeters for the MEG, followed by the high density EEG, 18 millimeters, and followed by the conventional EEG with only 20 channels, 23 millimeters. It's quite impressive localization for a so economical solution. We also observed that localization error was significant for good outcome compared to poor outcome patients. This makes sense because in the good outcome patients, we know that the epileptogenic zone was localized accurately and resected. And intracranial EEG was our gold standard, a localization error of approximately 7 millimeters, followed by the MEG, around 13, 14 millimeters, high density EEG, 15 millimeters, and the conventional EEG, 23 millimeters. The problem with the conventional approach in analyzing the spikes with the dipoles is that we use an a priori selection of thresholds, like goodness of fit, for example. We keep all the dipoles with specific goodness of fit below 80 or 90%. We believe this is noise. We get rid of them. However, this kind of threshold is kind of problematic because it depends on several factors, including the number of the channels, especially that's important for the EEG. So with my group here in Boston Children's, we introduced the idea of clusterness. And with this idea, we assign in each of these dipoles one value that indicates how many dipoles are in the neighborhood of this dipole. Areas with high level of clusterness indicate high epileptogenicity. Areas with dipoles that they have low levels of clusterness, they indicate low epileptogenicity. And by using this kind of concept, We published this work back in 2021 in a group of children with normal MRI and drug-resistant epilepsy. These are the most cases. So we found out that the precision to the seizure onset zone was significantly higher for both the EEG and the MEG for the clustered compared to the scattered dipoles, while the distance to the seizure onset zone was significantly lower for the cluster compared to the scattered dipoles. We also observed significant differences in the distance to resection for both EEG and the MEG for the patients with good outcome compared to the poor outcome for the clustered dipoles. And by using these tools, we're able to help the physician to solve difficult clinical cases. This is an interesting case. We published this case back in 2022, 1 year ago. It's a teenager who suffered from epilepsy for 16 years. She visited 3 different hospitals in the country. She had presurgical evaluation 2 times before. Contact Scott Perry, our medical director, and he's the head of the neurosciences. They refer also this patient to our research center. So we record simultaneously MEG and high-density EEG. We identify several enterical spikes in both modalities. And by using this algorithm with the clusterness, we find out with the low-density EEG, the high-density EEG, and the MEG, a group of dipoles in a focal area that have high levels of clusterness. The clinical team was convinced that reevaluate the case. The MRI was still normal, but they observed a tiny hypometabolism on the PET. They decided to implant stereotaxic EEG electrodes. We localized several seizures that they come from exactly the same or similar to the same location where the MEG and the high-density EEG data were indicated. They ablate this area with laser ablation, the seizure-free after 16 years suffering from seizures, and it still remained free of seizures after 1 year of surgery. That's another case here at the Boston Children's. This is a child with tuberous sclerosis complex. This is a genetic disorder. This kind of kids, they have several tumors in the brains. The goal we have is like to identify which tumor is the epileptogenic and be resected. We identify several spikes on both the MEG and then both modalities, they indicate a tight cluster of dipoles in a focal area of the brain in the vicinity of a big calcified tumor. This calcified tumor was resected and the child became seizure-free. The problem with the MEG system is that it has been exclusively designed for adult use. This is an idea that Yoshi Okada and together with Ellen Grant, they work at Boston Children's in order to make the setup of the system here at Boston Children's like several years ago. So they designed this kind of system that has a helmet that the sensors are closer to the head of the children. So the generators in the brain, brain generators, they are closer to the sensors. This is some data we published with the baby years ago. This is a 2-year-old boy with drug-resistant epilepsy. We identify several enterical spikes on the magnetometers covering the left frontal areas. We see a nice topographic mapping here indicate a possible underlying source. And we localize this kind of activity with dynamic statistical parametric model. We saw this nice activity in the vicinity of a focal cortical dysplasic lesion. Then the clinical team also investigated the PET. We saw a high hypometabolism in this area of the brain. This lesion was resected and the child eventually became seizure-free. We know that the MEG, they have different sensitivity profiles. We know, for example, that sources that they have a radial orientation, they can be seen very nicely in the EEG, but they're not seen in the MEG. And as the result of this kind of property, the MEG is also blind to deep sources because as we go more deep into the brain, the sources, they become radial. On the other hand, like sources with tangential orientation, they can be seen both in the EEG and the MEG. So some people, they came with the idea that if we combine information from these 2 modalities that are recorded simultaneously, we can have better localization results. This is a paper we published with my team at Cook Children's like last year. We identify interictal spikes both on the EEG and the MEG, and then we localize this kind of activity by using only electrical source imaging and the clustering, magnetic source imaging and the clustering approach, and also the combined solution, the fused solution, and we compare these localization findings with the gold standard. We use these two metrics, the distance from the clinical defined seizure onset zone and the distance from the resection. And what you see here in the first row is the data from the distance from the clinical seizure onset zone. The second row is the distance from the resection. For the good outcome patients that we know that the epileptogenic zone has been localized precisely, and for the combined solution of the EEG and the MEG, we saw that we have a localization error around 5 millimeters with the clustering. That's comparable with the invasive recordings. That's quite impressive localization ability, much better than the individual modalities. This is the areas under the curve for the raw curves like that for the prediction of the surgical outcome. The combined high density EEG with the clustering show the best predictive values compared to all the other modalities. So it's worth considering recording simultaneously high density EEG and MEG and combine these solutions into one fused solution in the brain. However, not in all cases, like all the cases they're not so easy to assess that we have a nice dipole cluster there that we can resect and the patient to become eventually seizure free. In several cases, unfortunately, we have scattered dipoles in all over the place or in covering a large area, or with distributed models, we have large areas of the brain which are active. And in these kind of cases, we believe that there's a whole network that is active, epileptogenic network. And the task now we have is like to identify the pathological critical hubs in this network and discriminate them from the nodes which they belong to the propagation in the network which are not involved in epilepsy. In order to do that, we use the concept of functional connectivity. I'm pretty sure that several of you know this kind of concept. It quantifies actually the temporal coincidence of spatially distant neurophysiological events. And we see here an example of functional connectivity on electrocorticographic data. We take a pair of time series between these two channels, and then we get one value of functional connectivity. And by functional connectivity among all these pairs, we observed, we get this kind of functional connectivity matrix that give us a quantification of the functional connectivity network, of the connectivity in the brain. Based on this kind of concept of functional connectivity, this is a paper we published last year in Scientific Reports with my group at Cook Children's. We analyzed intracranial EEG data from 31 children with drug-resistant epilepsy. We estimate the functional connectivity among all these nodes, and we found out that functional connectivity can discriminate different epileptogenic states. For example, we saw low values of functional connectivity during interictal and preictal states compared to ictal and post-ictal. So this means like before and after the seizure. But the most interesting finding was about the surgical outcome. We found that functional connectivity was significantly higher inside of the resection compared to outside for good outcome patients, but no differences in the poor outcome patients. Based on this data, we tried to examine whether we can replicate these findings non-invasively with the MEG and the high-density EEG. This is a paper we published recently in Brain. We implanted electrodes. Virtual sensors on exactly the same locations where intracranial electrodes they were placed later in the same patients. And in these virtual sensors, we extracted MEG and EEG activity with spikes and without spikes. We estimate functional connectivity values as well as graph centrality measures. And what we found, we actually replicate the findings of the previous study. So in the invasive recordings, here's the intracranial EEG data. We found significantly higher functional connectivity inside compared to outside the resection in only good outcome patients, not in the poor outcome patients. And it was quite impressive that the same findings. They were replicated by the MEG and the high-density G by the non-invasive recordings. Increased functional connectivity inside compared to outside resection in only good outcome patients for both the MEG and the high-density G. No differences in the poor outcome patients. This is an interesting case from a representative two patients, a good outcome and a poor outcome. This is the first row is intracranial EG recording. The second is like high-density EG data, and the third one is the MEG data. In the good outcome patient, we see here with red the high functional connectivity nodes. They were always inside of the resection. We observe high also consistent data between the invasive and the non-invasive methods. Contrarily, in the poor outcome patient, we saw high functional connectivity values outside of the resection. The resections here with green. And this spot probably either was missed by the clinical team or was not resected because was overlapping with the local cortex. We discussed so far about the spikes and the irritative zone, and then we said that this has high sensitivity, however, does not have good specificity. And then this is because a very large area and always overlap with the local cortex. So even if we resect all this area, the patient will become possibly seizure-free, but will have significant functional deficits. For example, we not be able to walk again or talk again. So we need more specific biomarkers, and this is what the ICTAL or the seizure onset zone offer to us. Is the brain area where the seizures are initiated. The problem with that is like we should wait for a seizure to occur. So usually we bring the patient, the hospital stays for several days with intracranial recordings in place, and we're waiting for some seizures to take place. With my team here in Boston Children's, like a few years ago, we examined the idea whether the low density conventional EEG that we show that has kind of a decent localization abilities can indeed localize the seizure onset. This is data from a cohort of children with drug-resistant epilepsy. We identify the onset of the seizures on the scalp EEG, and then we localize this kind of activity with dipole feeding and with distributed model called S-Loretta. We compare this finding with invasive recordings, and we found that we have a quite decent specificity, sensitivity, and accuracy to predict surgical outcome. This is another study, but using the same or expanding the same idea. By using conventional scalp EEG with only 20 channels, like we estimate virtual channels in the same location where intracranial electrodes they were placed, and we're able like to project the non-invasive seizures inside of the brain and identify non-invasively the seizure onset zone and predict the surgical outcome in the patients. So what I described so far concerns about the presurgical evaluation in the phase 1, where all these tests are non-invasive. In several of these of the cases, the results of this tests are either inconclusive or non-concordant. And in this kind of cases, like as we said, like the patient, they go to phase 2, we place electrodes inside of the brain, either directly on the cortex, what is called electrocorticography, or with stereotaxic EEG, we place depth electrodes inside of the brain in more deep areas of the brain. And this kind of recordings, they allow us like to also record other kind of biomarkers because we have very good signal to noise ratio. We are able to record what's called high frequency oscillations. They are defined as short, spontaneously EEG patterns of at least 4 oscillations which in the EEG signal. And they are classified into frequency zones in the ripple zone between 80 and 250 Hertz, and the fast ripple zone between 250 and 500 Hertz. The ripples, they are less specific to the epileptogenic zone because can be seen in also physiological areas, but can be seen in most patients with epilepsy. On the other hand, the ripples define the fast ripple zone is a very specific biomarker of the epileptogenic zone, but it's hard to be detected with microelectrodes and can be seen in few patients with epilepsy. So the idea came because we see now that the different biomarkers, they have different advantages and disadvantages. The idea came that if we combine features of these biomarkers, maybe we'll have something better. Some people, they have hypothesized that spikes overlapping on ripples, if we have a spike and then a ripple on the top of this is what's called a red spike. this is a better biomarker than all the other interictal biomarkers. With one of my PhD students, we work on this project. Unfortunately, we didn't find positive findings. We reject our hypothesis that red spikes are better biomarkers. Actually, they are not better biomarkers than the green spikes. So when we see a spike overlapping with a ripple, it's not better than any kind of other spike or spiky activity. One of the limitations of the intracranial EEG is that it has limited spatial resolution and limited coverage. And this is because we cannot put electrodes in all over the place. With my team, we expand the idea of using electrical source imaging, not now on the MEG or the high-density EEG, but also on the intracranial EEG recordings. And by doing this kind of approach, we show that we are able to define the clinically the seizure onset zone and the irritative zone with better sensitivity and specificity compared to the conventional clinical methods. One other observation and work my team is doing about the propagation of interictal activity. This is a paper we published in Brain last year. We observed that the spikes, they don't occur at the same time in all channels or as isolated events, but they actually propagate across large areas of the brain. And the hypothesis that the onset of this propagation is a more precise indicator of the epileptogenic zone compared to the areas of spread. Use this kind of concept with the electrical source imaging, and this allows us like a precise mapping of the spatiotemporal phenomenon with high spatial and temporal resolution. And by using this kind of approach, in 43 patients with drug-resistant epilepsy, we defined 3 different areas of propagation: the onset zone, the early zone, and the late zone. And also, we estimate the effective connectivity among these areas to see the information flow among these regions. We found that significantly higher in the onset compared to the areas of spread only in the good outcome patients, while the distance to resection was significantly lower in the onset compared to the areas of spread for the good, but not for the poor outcome patients, while the onset of this propagating activity had higher predictive values of surgical outcome compared to spread or even the clinically defined seizure onset zone. Another interesting observation was that, like in good outcome patients, the information flow was from the onset to the areas of spread. An interesting finding indicates that probably in the rectal spikes, they propagate information from the onset to the areas of spread, similar to the seizures. This is a work we have done back here 2018 with my group here in Boston Children's in the Leonora Tamiglia. We observed that similar to the spikes, the ripples also, they propagate across time. We published this paper in Annals of Neurology in 2018. We hypothesized that resection of the onset is sufficient in order for the patient to become seizure-free. And indeed, like this was, we proved our hypothesis. Resection of the onset ripple zone was associated with good outcome, with a positive predictive value of 83% and negative predictive value of 60%, while resection of the spread ripple zone was not associated with surgical outcome. This is an example of a good outcome patient and a poor outcome patient from the same cohort. You see here with this magenta color, the resection. In the good outcome patient with black is the onset of the ripple zone was resected and the patient became seizure-free. Patient, despite all this big resection, this onset of the ripple was not resected and the patient was not seizure-free. This is a work we started recently with one of my PhD students at Cook Children's. We analyzed in the same cohort 3 different biomarkers, interictal biomarkers, the spikes, the ripples, and the fast ripples. They propagate. And our hypothesis, we map all these areas in the brain, and our hypothesis was that to examine whether the ripple and the spike propagation onset, they overlap each other, and whether this kind of overlap area is a more specific biomarker of the epileptogenic zone compared to the individual onsets. We found that spike and ripple onsets, they overlap each other in most patients in the cohort. Fast ripples, they occur in only 32% of the patients, and that was expectable. We know that it's a very specific biomarker, but it's difficult to capture. In good outcome patients, the spike ripple onset zone was the closest zone to the resection. It has the highest overlap with the resection, while there's no difference in overlap and distance from resection compared to the clinical defined seizure onset zone and to spike ripples onset zone. All onset zones and the spike ripple onset were close to resection, have a higher overlap to resection in good compared to poor outcome patients. Also, we found that the onset zones, the clinically defined seizure onset zone and the spike to ripple onset, they outcome, but the spike ripple onset was the best predictor of surgical outcome. It was performing even better than the clinical defined seizure onset zone, and it was comparable only to the ripples, but fast ripples can be seen only in a few patients, while this biomarker can be seen in almost all patients with epilepsy. With one of my postdocs, we explored the idea of using artificial intelligence. Everybody's working with that right now in order to mapping the epileptogenic zone. He used an unsupervised machine learning method to analyze intracranial EEG data with interictal activity. And actually, he used this machine learning to extract brain networks, a network that is active during epilepsy and the background activity, and also to extract active segments of activity in the time series. This is data from interictal spikes. You see here the interictal activity on the intracranial EEG, and then this is data from ripples. And you see that the artificial intelligence algorithm was able to identify automatically and with an unsupervised approach, like quite accurately, this kind of events. But much more interesting was the fact that it was able to identify active networks into the brain. You observe that like in this active network, the activity, the power was significantly higher inside compared to outside of the resection in several frequency bands in patients with good outcome, but not patients with poor outcome. So this is a work about HFOs. We discussed that HFOs can be detected invasively because the intracranial recordings have high to signal to noise ratio. However, this limits the applicability of the HFOs to the late stage of the surgical workup and to a restricted pool of patients. So with my group, we have done some work to examine whether with non-invasive full head techniques like the MEG and the high density EEG, we're able like to detect this kind of activity non-invasively. This is work that is done here with Steve Staffelman and Tanaka, Naoru Tanaka, and several other groups. They have shown that now HFOs, they can be detected non-invasively in the ripple frequency band with MEG and high density EEG. This example of EEG recording and a MEG recording, we see here that if we filter the data in a specific frequency band between 80 and 150 hertz, we see nicely this kind of ripples in the specific frequency band between around like 100 hertz, 90 to 100 hertz. However, in order to localize this kind of activity, we cannot use like dipole fitting. We need a kind of special techniques that consider the activity from a whole time window. In order to localize this kind of activity of high frequency oscillations, we use the wavelet-based maximum entropy on the mid method, and we're able like, to localize this activity with high precision. You see how focal was this kind of activity in an area of the brain. Both MEG and EEG, they show the same, almost the same spot. Very, very focal activity, much more focal than the spikes that they defined the irritative zone was like very large area. And in this patient, this area was resected and the patient became eventually seizure-free. By exploring this idea with my group here in Boston Children's like a few years ago, we also test the idea of the red and the Greek spikes with non-invasive data with the MEG and the high density EEG. We found that the EEG can detect more high frequency oscillations than the MEG, while the high frequency oscillations with spikes are more frequent than HFOs without spikes. But the most interesting finding was that the HFOs without the spikes, they were less likely to be epileptogenic because they can be seen in also other physiological regions. It was they were observed also in areas which were not covered by the intracranial EEG. This is the findings from the non-invasive mapping of this ripple propagation. We published this paper back in 2021. We saw that similar to what we observed with intracranial EEG, we can replicate these findings with the MEG and the EEG. We can see a nice propagation of ripples across channels. We actually mapped this activity with virtual channels on the same locations where intracranial electrodes they were placed later. And then the onset, we hypothesized that the onset of this propagation was more epileptogenic than the areas of the spread. This was confirmed our hypothesis. We observed a significant lower distance to resection for the virtual ripple onset zone compared to the entire ripple zone in the good outcome patients, and a higher percentage of the resection in the ripple onset zone compared to the entire ripple zone. So we can confirm that like resection of this onset area detected with MEG and EEG non-invasively can predict surgical outcome better than the areas of spread. So I will close my talk with discussing about the loquent cortex. We discussed so far that how we can identify the areas that we should resect in order the child to become seizure-free. We should map also the areas that we should not resect. And then these areas, they are defined the loquent cortex. Then we have the somatosensory cortex, the motor cortex, auditory cortex, and language areas. We have the visual areas. And we know that we should not touch these areas on the patient because otherwise the patient will have significant functional deficits. With my group at Cook Children's, we have developed new ideas of how to use more complex tasks and video games to make the kids interesting in these kind of tasks. Usually in most of the clinical places, they use boring tasks that they have been used for several years, and kids are not interested in doing that. So by using this kind of new ideas and new complex experiments, we're able to map the loquent cortex, the visual and the auditory functional areas. With one of my ex-mentees, we are working on how to map with pneumatic stimulator the entire somatosensory network in children with drug-resistant epilepsy. That's the last slide from my scientific findings. As I said before, children with epilepsy, they don't suffer only with recurrent seizures. They have other comorbidities. We can see here that compared to the general population, children with epilepsy, they suffer from significant levels of depression and anxiety. Investigators in my team, Crystal Cooper, she's doing an excellent work on this kind of topic. She examined a task that is called emotional phase word stroop. It's like emotional conflict, examine the emotional conflict in children with epilepsy, and she observed significant difference between healthy kids and typically developing kids in several areas of the brain, and correlate this kind of activity with the levels of the anxiety in children with epilepsy compared to the healthy controls. So I would like to conclude my talk with the following message, that there's novel, invasive and non-invasive biomarkers of epilepsy, that they can augment the presurgical evaluation and improve the surgical outcome of children with drug-resistant epilepsy. I would like to be sure that there's visibility of this kind of work to the clinical teams who make this kind of decisions to use these tools more. I would like to thank all my ex-mentees, several people here in Boston, but also in Texas or in Europe. They excel either in industry or academia. I have been mentor for these people for several years, but I would like mostly to thank the patients and the families who participate in our research, and most importantly, my team who do all this great work. Thank you so much.